you hear me? Those of us that has joined.
Yes, ma'am.
Yes, we're going to have a doctor from Lily Women Health. He's going to speak to us about breast cancer in pregnancy. He will speak about breast cancer generally, then he will speak about breast cancer in pregnancy. I have seen some women during their first trimester or their mid-trimester, having to have a breast lump removed. And once the breast lump is removed, we send it for histology. The report of the histology will determine what the history of the lump, or how the lump will be taken care of. But this morning, we are going to have this doctor with us, Dr. Femi. He's from Lily Women Health, and he's going to tell us everything that we need to know about the lump, the breast cancer, and how to take care of it in pregnancy and after pregnancy. So in 2 minutes, we will ask him to come in and he will speak to us. And after the teaching, I want all of us to have our questions ready. As he's teaching and you are having questions in your mind, you can write it down so that after the teaching, you can start asking the questions so that we won't take too much of our time during the program. So, Dr. Femi, are you in the house?
Good morning, everyone.
Yes, good morning, Dr. Femi. It's almost 11:10, and I would like you to take over and speak to our mothers about the topic that we have given them on the platform. Over to you, Dr. Femi. Hello, Dr. Femi.
Yes, I'm with you.
You can share your screen so that we can follow you.
That's what I want to do right now. Thank you.
You're welcome.
Yes. Just a few minutes. Good morning.
Yes. Okay.
Yes, I'm logging in soon.
Yeah, okay.
Yes. All right.
Okay. I hope our mothers can see the shared screen. Hello.
Okay, good morning. I hope you can all hear me.
Yes, we can hear you. Go ahead.
All right.
Okay. Good morning, everyone.
Good morning.
Booting up, but while it's booting, I am Dr. Laguda Idris. So I'm here to talk about breast cancer in pregnancy. I'm the medical rep of Lily Women's Health, where we deal with anything that has to do with diseases associated with women, especially cancer, especially. So, breast cancer is something that it does not only affect people physically, also affects people emotionally, psychologically, not only to the patient, but even to all the caregivers, the family, the husband. It's a scourge that many of us don't want to pray for even our enemies. And I'm sure most of us will even be so surprised that breast cancer can even occur in pregnant women. But it does. It could happen to anybody. Pregnant, non-pregnant, elderly. Even as a doctor, I have seen a 25-year-old lady having breast cancer. Before, we used to say, no, it's only when you're 40 years and above. No, nowadays, we're even seeing younger ones having breast cancer. And it's quite alarming. So we all need to be careful. We all need to take precautions. We all have to make sure we do our breast self-examination, which I will still explain later. But we shall focus on the topic of today, which is breast cancer in pregnancy. We'll go through this outline, do a little bit of introduction, go through the epidemiology, run a little bit on the anatomy, talk about the risk factors, histopathology, but I will focus more on the clinical presentation because that's what we really need. We really need to know how this cancer manifests itself. Because most of us, yes, I know a lot of us, when we see a lump, we'll be like, there's a lump on my breast. Oh, yeah, I want to go and see the doctor. And no, it's not. Yes, it's good to be vigilant. It's good to be very, very careful. But I also want to explain that it's not all lumps that are cancerous. Then I'll also talk about, and that's where I'll lead to differential diagnosis. Then I'll also let people know how this breast cancer can be diagnosed. It's not just about the doctor or the nurse or any health worker. Even you, as a layman in quotes, you should know, you should have an idea of how these things are done. Because it's going to be very bad for anybody in this present age to not know what a mammogram is or to not know what mammography is all about. So I will go into that. Then, of course, the treatment, go a little bit on special considerations, prognosis, then I'll conclude. And I will make sure I won't waste much of our time. They gave me 15 minutes, but I'll try as much as possible to run it through in a lesser time. Breast cancer is the second most common malignancy in pregnancy, and it just follows cervical cancer. Is the second most common all over the world. Cervical cancer is the commonest, then followed by breast cancer. Other cancers can come up, lung cancer, skin cancer, and all that. But the reason why breast cancer is very important is because, of course, it's the breast. Breast cancer, even though it could occur in men too, but it occurs 10 to 50 times more commonly in women than in men. So because the women have breasts, that's one. Then secondly, another important thing is when breast cancer occurs in pregnancy, the prognosis is usually poor. Prognosis means the outcome. What could happen? Would the person survive or would the person not make it? And especially in this country, most of the time, they don't usually make it. Sorry to say, because of our health, the health situation in this country. Healthcare in Nigeria, sorry to say, it's nothing to write about. And we pray it gets better. Diagnosis and treatment of breast cancer during pregnancy encompasses many diagnostic and therapeutic dilemmas. What I'm trying to say here is it's a multidisciplinary approach. It's not just the gynecologist or the general surgeon. A lot of people, the social workers, the psychologists, the psychiatrists. In fact, I will even explain that any form of cancer can even make the endocrinologist to come up because the blood sugar may rise up. It may lead us to even call the, apart from the general surgeon and the gynecologist, we may want to call the psychiatrist because, they will want to be depressed, or the clinical psychologist. Then we'll also call the histopathologist because while we take a biopsy, we have to confirm if it is really cancerous and even know if it has spread. We'll call the radiologist, and that we will talk about mammogram. I will explain that in detail later. The overall survival of pregnant women is generally worse than in non-pregnant women. And that's why it's very important we have this talk. Many people don't even know that breast cancer can occur in pregnant women. They just believe it's only in the elderly. Even young people can have breast cancer. We all need to be careful. And that's why, even while we are pregnant, we should still do a breast self-examination, especially those that have a family history. If, sorry to say, a mother, an aunt, a grandmother had breast cancer in the past and unfortunately succumbed to it, we all have to take extra precautions. Breast cancer in pregnancy is defined as breast cancer diagnosed either during pregnancy or in lactation or within 12 months postpartum. Postpartum means after birth. So it's not just during pregnancy. While lactation, while breastfeeding, that's the meaning of lactation, or even 12 months after birth, once it is diagnosed that a woman has breast cancer, we put it as breast cancer in pregnancy. Breast cancer occurs in 1 of every 3,000 pregnant women. It's usually metastatic. Metastatic means it spreads to other distant organs and tissues. The cancer that's supposed to be in the breast is now beginning to spread to the lung, to the bone, to the stomach, to every other organ in the body. Spreads to, and that's where the prognosis is even the worst. Once the cancer has started spreading to other organs of the body, we just try to keep the patient alive till God knows when. So it's very, very important. The age range is from 32 to 38 years, but an average of 34 years. If we notice this, it occurs during the prime of childbearing age, 32 to 38 years. That's when most women usually start having children. So one has to be very, very careful. Even though it could occur, quite rarely, it could occur in younger women and, of course, the elderly primary gravida, that's 40 years and above. Those that have been trying to conceive, they later got pregnant above 40 years. They should also be very careful because by the time they start seeing lumps or lesions on their breast, then they will have to quickly go to the doctor to confirm if it is cancerous or not. The incidence of breast cancer in pregnancy is estimated to be about 1 in 3,000. Like I said, this is a worldwide epidemiology study. Not much is done in Nigeria. We don't usually do much research, but as doctors, we have seen while I was a medical student, I saw one case of a pregnant woman with breast cancer. That was in University of Ilorin Teaching Hospital. I saw a case. So it's not that common, but it does happen. And one has to be very, very vigilant about it. 10% of breast cancers are diagnosed before the age of 40 years. Like I said before, the average age is 32 to 38. Now, the mean or median gestational age at diagnosis is 17 to 25 weeks. Now, gestational age means the age of pregnancy while you are pregnant. Since when you took in, since when you are confirmed to be pregnant, and usually calculated from your last menstrual period. So if you are 17 to 25 weeks, is at that peak age that we usually diagnose breast cancer in pregnancy. Even though it can still occur even at late trimester or even early trimester, while some ladies don't even know that they are pregnant. We just have lumps, and when we do biopsy, we find out that it's already cancerous. Let me just run a bit through on the anatomy of the breast, because as mothers, we should know a little bit about our breasts. We should know that it's a modified sweat gland. We have sweat glands all over our skin, which produces sweat. But God, out of his magnanimity, modified 2 sweat glands to become breasts. So instead of secreting sweat, they secrete breast milk. The greater part of the gland lies in the superficial fascia. That's a fascia is like a covering of a muscle. So we have the skin, then the breast is underneath the skin, then the fascia, then the muscle. It usually occurs from the 2nd to the 6th ribs in the 2 sides, the 2 sides of the chest, horizontally from the lateral border of sternum to the axillary line. There is a muscle on the chest. It's called the pectoralis major. It's always overlies that muscle, except maybe it's a supranumeral mammary gland in any part of the body, but that's another topic for another. The parenchyma. Parenchyma means the external portion of the breast is about 15 to 20 lobes, and these lobes that secrete milk. These are the lobes that secrete milk, and each lobe is made up of 20 to 40 lobules. So one lobe, 15 to 20 lobes, one of those lobes contain 20 to 40 lobules. So these lobes are what secrete the milk for the baby. So that's just the diagram there. Lactiferous duct, the lobules, the lactiferous muscle at the back, the ribs, and so on and so forth. Pregnancy induces both proliferation and differentiation of the mammary epithelium. With all this grammar that I'm just speaking is, when a woman is pregnant, the breasts become bigger. That's it. And that's why it's at that peak time that cancer, you see, during pregnancy, the breast becomes bigger. Now imagine if a woman now has cancer. The cancer grows faster. Now we see why breast cancer in pregnancy is more dangerous than breast cancer when a woman is not pregnant, even if both of them are dangerous. But breast cancer in pregnancy is more dangerous because while the woman is pregnant, the breasts are growing, the cancer too is growing. So we need to be careful. Both lobular and alveolar growth occur, and including fatty tissue too. And the factors that determine this include the weight and the blood supply, because the breast has very good blood supply. Blood is flowing into the breast to nourish the breast and to give the nutrients when it's time to produce milk. Then differentiation of the alveoli into mature milk-producing cells requires the stimulus of cortisol, insulin, and prolactin. These are the hormones that bring about milk secretion and differentiation of the breast tissue itself I hope this is not getting boring for many of us here, because I know these medical terms may be very heavy, but I'm just trying to simplify this so that all the mothers here will be able to understand how this relates to breast cancer in pregnancy. The risk factors include age, like I said, 32 to 38 years, median of 34, but we should also bear in mind that it can still occur at any age. So if you are above 40 and you feel I'm pregnant, I'm above 40, doctor said 32 to 38, I'm above 40. No, it can still occur at any age. We just know that the peak is 32 to 38 years. But we should also bear in mind that it can occur even if you are 45 years. Now, a family history is very, very important, because about 70%, 60 to 70% of breast cancer is hormone related and is genetically inclined. There is a gene called HER2, hormone estrogen receptor 2. That gene is always linked to breast cancer. There is another one, BRCA, BRCA. That gene too is always linked to breast cancer. In fact, in the US, they usually do this BRCA typing, in which if a woman is seen to be BRCA positive, they usually advise those women to do a mastectomy to remove the breast, because once a woman is BRCA positive, there's a 50% chance that she will have breast cancer. So one has to be very, very careful. And if you have had proliferative breast disease, even if it's a benign fibroadenoma, any lump that is seen after a biopsy and everything is seen to be benign, one has to still be very, very careful. If you're having other lumps, still take it out, still do a histopathology. Let's see whether it's cancerous or not. Of course, environmental factors. Nowadays, we don't know what we eat. We eat all sorts of foods that will just bring about free radicals. We drink alcohol. Even I've seen a lot of women that smoke heavily. Women that work in all these heavy chemical and industrial plants. And nowadays, all these exhausts from cars, air pollution, we inhale all sorts nowadays. We eat all sorts of food. We don't do exercise. We live a sedentary lifestyle. All these facts. In fact, a lot of women apply bleaching creams, bleaching soups, all sorts of organic in coats, all sorts of organic soups, organic creams. You don't even know what they added to those creams. And people still apply it on their body. People will be applying creams to enlarge their breasts, and they don't know what they put there. They will say they put olive oil and all that. Oh, we're so sure it's really olive oil. The breasts become bigger, but you don't know if they are even causing cancer in the breasts. One has to be very, very careful with all these things that we put into our mouths or we even apply on our skin. One has to be very careful. Obesity is a very common and very important risk factor. If you are obese, you are more likely to have breast cancer. So if one is obese, one will have to reduce the weight. And also physical inactivity, living a sedentary lifestyle, sitting down at home, pressing the remote, driving all the way to work, sitting down at work, no form of activity, coming back, driving down, no form of activity, coming back home, sitting down, pressing the remote, then going back to sleep. No walking, no jogging, no form of exercise. All this can predispose to cancer. Any form of malignancy is just another word for cancer. It may not just be breast cancer. If one has had colon cancer, stomach cancer, skin cancer, any form of cancer before, is also likely to have breast cancer. And like I said, smoking. You see women, we forget the men that smoke. Women that are smoking, and you know that your breasts are there and this can predispose to breast cancer. Please, let's stop smoking. Let's all stop smoking. And like I mentioned before, BRCA1 and BRCA2 mutations. These two the BRCA genes, they are very, very important In other countries, developed countries, they do a BRCA screening for women. If you are BRCA positive, they advise you to do a mastectomy so that you won't have breast cancer in future. Dietary factors, like I said, no fruits, no vegetables, more of fats, more of processed food, fizzy drinks. You don't eat healthily, you don't eat good food. All these free radicals that are generated, the body is trying to get rid of all these harmful substances. They produce free radicals, which now bind to breast tissue and destroys the DNA, which now mutates it and lets it form cancer. We should all try as much as possible to eat healthily, more of vegetables, more of fruits. Forget all this junk food that they produce nowadays. Let's eat more healthily. We can't always overemphasize the fact that in the olden days, our grandmothers, our great-grandmothers used to live long, very, very long, and they are still strong and very agile because they eat from the farm. They eat good food. They don't eat all these pizza and all that everybody is eating nowadays, that in the end, now people now start coming down with all sorts of diseases. Let's try and eat healthily. I will just run briefly on the histopathology. Ductal carcinoma, that's cancer from the duct. It covers for 79% of cancers. Other ones include the lobular cancer, tubular, mucinous, medullary, and papillary cancer, but that's just by the way. Now, the clinical presentation. I made this as a pictorial representation so that we can compare to our breasts and see if we have it. Number one is a lump. Once you have a lump, please just go to the hospital for history and examination. Any lump is soft, is hard, it's movable, it's not movable, it's fixed, it's painful, it's not painful. Please go to the hospital for a checkup. Do not overlook any lump. Please do not overlook any kind of lump, whether it's regular, it's smooth, it's hard. Once you have a lump, please go to the hospital. Now, I need to emphasize that at some point during the menstrual cycle, the lobules can be bigger. It can be more enlarged slightly at that time, and it could cause a little bit of pain, just a bit. So at that point, even if you still want to see a doctor, the doctor may just counsel and reassure you that this may likely not be the lump that we're talking. It's just the lobules that occur when they enlarge during the menstrual cycle, and then a little bit before menstruation or during the ovulatory period. So that's by the way. Also, discharge or bleeding, especially bleeding. Once you are seeing blood coming out of the nipple, it's a telltale sign. You have to quickly rush down to the hospital and complain. Some people just overlook that maybe it's because of friction on the brow or something. No. Any form of bleeding, especially when you press it and you see bleeding from the nipple, and if it's a discharge, it may be another endocrine disorder, that's hyperprolactinemia, but that one too, you still have to see the doctor for that. And also during pregnancy, the breast may excrete a little bit of milk, especially in the late trimester. That one, it is not that common, but at the same time, it's rare. So one will have to take note of all this. If there is any change in the size or the contour of the breast that was round before, that now has a little contour, it has pressed in quotes, or one breast is bigger than the other, and it has not happened like that before. Usually, during puberty, one breast is usually bigger than the other. And even some adult women to note that their one breast is bigger than the other, or one is lower than the other. That one is still normal. But if suddenly you know that you already know the symmetry of your breast, but you notice that one is beginning to grow bigger than the other, one has to be very careful. You really need to see your doctor. When there is redness or pitting of the skin over the breast, just like the skin of an orange. We doctors, we call it peau d'orange. It's a French word, orange skin. When it's hard and depicting when you see an orange, the way an orange looks like, if you compare it to the breast, that there is reddening, there is dimpling, pitting on the breast, please rush down to the clinic for a checkup. If there is any change in the color or the appearance of the areola is that dark part which surrounds the nipple, rather. It surrounds the nipple, that dark part of the nipple or the breast, that's the areola. Now, if that areola has changed color, we all know that it's darker than the other part, but if it's now becoming darker than before, you notice that especially on one breast, not even on the two, one has to be very, very, or if that areola is spreading, the darkness is beginning to spread outwards, one has to be very, very careful. You need to see the doctor. Also, nipple inversion. Once the nipple has inverted, it has gone inwards and not outwards, it's a telltale sign. So actually, during pregnancy, most times the nipple may be inverted. Yes. And that's why some women, especially first timers, they usually have difficulty in breastfeeding. At that time, there's usually a little difficulty. But that one is still something that we can still handle. But if you notice suddenly that the nipple has inverted in itself, we should still see the doctor for a checkup. The differential diagnosis may include, of course, carcinoma, that's cancer. Then it could be a galactocele. It's more or less like a cyst in the breast. It may or may not contain milk, but it always contains liquid. It's a cyst in the breast. Cyst is any mass that contains any kind of fluid. It could be serous fluid. It could be any kind of fluid. Breast abscess is where there's pus in the breast. Pus, which could be usually due to infection, bacterial infection. And when there is breast abscess, one usually does a HIV test to be sure that the person is not immunocompromised. Then there's lactating adenoma, fibroadenoma, fibrocystic disease, lobular hyperplasia, and so on and so forth. That's for the doctor to rule out. The diagnosis should be made by a combination of clinical assessment, radiological imaging, and cytological or through histological analysis. Let's note this. The clinical assessment is for a doctor to take a history and to do a breast examination on you. That's just it. The first point of call is always a doctor. Any breast lump or anything, see your doctor. Doctor will ask a lot of questions, especially concerning family history. Then would ask other questions, history of smoking, history of using bleaching creams, history of industrial, working in any heavy chemical environment, and so on and so forth. And then the age, of course, and other biodata. Then imaging, breast scan or mammogram. And of course, pathology, that's fine needle aspiration, cytology, or the cutting, that's the excisional biopsy. And this gives a confident diagnosis in 95% of cases. Ultrasound is for evaluation of the palpable breast mass during pregnancy. It distinguishes solid from cystic masses. Most times the cystic mass is not always cancerous, but we never say never in medicine. So if it's a solid mass, one will now want to rule out if it's just a fibroadenoma or clear-cut cancer. And one good thing about ultrasound is there is no radiological exposure to the fetus. And it's also used in ultrasound-guided biopsy. So we put the ultrasound probe and the histopathologist will just take the biopsy from there and take it to his lab for analysis. A mammogram, if you use a mammogram is just a modified X-ray on the breast. And this is usually for elderly primigravidas or elderly pregnant women, because the reason why is for mammogram in younger age group, the fatty tissue is well differentiated at that time. So a mammogram will not really want to penetrate through the tissue itself. So, but for elderly people, by that time, the fatty tissue has lost most of its moisture, water content, so it's not well differentiated. So at that point, you'll be able to take the stroma or the parenchyma better at that time in elderly from 40 years and above. So like I said, the increased water content in the breast may decrease sensitivity to about 70%. So that's why mammogram is not usually done for women less than 40 years. So as you can see, for doctors, this is how we differentiate between a malignant and a benign mass. A benign mass is more rounded, it does not spread, but a malignant mass is more like a spider web, it's spiculated, just like the spokes of a bicycle. It has a spiculated appearance or a spider web appearance. So when a radiologist sees this, he would know that this is likely cancer. But the gold standard is a biopsy. It's the histopathologist that gives the gold standard diagnosis of breast cancer. So when you do a biopsy, you know that that person already has breast cancer. And the sensitivity is about 90%. It's either a core needle or a fine needle aspirated cytology. Any of this can be done to diagnose breast cancer. Other investigations that can be done, of course, the normal full blood count, kidney function test, liver function test to know if there is any spread to the liver, kidneys, tumor markers, and so on and so forth. But that's for the doctor to decide. The treatment depends on the stage of the disease, the hormone receptor status. That's why I was talking about BRCA1, BRCA2, then HER2, hormone estrogen receptor 2 receptor status. Those genes are very important in breast cancer. And of course, the gestational age and what the patient himself prefers. If the patient prefers surgery or chemo or radiotherapy or whatever, but all this should be done in due time. Treatment can be surgical, it can be through chemotherapy, radiotherapy, and of course, supportive therapy. The protocol of treatment should be as close as possible to non-pregnant state. There is always a multidisciplinary approach. The surgeon must be there, the radiologist must be there, the interventional radiologist must be there. Everybody must come into place. The first line of treatment is always the surgery, and that's mastectomy to remove the breast, and of course, conservative surgery. There is always a selection criteria for breast conservative surgery, and that's when we talk about the TNM staging, where we check the tumor, then we check the axillary lymph nodes. That's the lymph nodes under the armpits. If they are beginning to swell up, there's little metastasis going on already. Then, of course, if there is any evidence of metastasis in any other part of the body, which could be in the liver, in the kidneys, the bone, wherever, single lesion clinically and on mammography, you just do conservative surgery. You don't remove all the breast. You can just remove that lesion and some other parts of the breast and do a little bit plastic or cosmetic surgery to that. The tumor must not be larger than 3 cm. Tumors more than 2 cm, which are away from the nipple or areola, you can still do a conservative surgery. Lesion of lower histological grade and there is no lymph node enlargement, that's where you can do the breast conservative surgery, that you can still conserve the breast. When all these criteria are not there, the best bet is just to remove the whole breast. That's the best, as bad as it can be. And that's why sometimes you call the clinical psychologist to counsel the patient, to reassure the patient, and to do some psychotherapy therapy because it's not easy for a woman to cut off her breast. Some will still say, no, they will die with the breast. I know a lot of women that are non-pregnant women, they will say they are not removing their breast, they will die with it rather. But it's not done. One has to live, one has to survive, not only for your husband, but even for your children and your grandchildren. Conservative surgery may include wide local excision or a quadrantectomy. Quadrantectomy means you divide the breast into 4. After cutting in 4 places, you just remove that quadrant, which is more affected, then do a little cosmetic surgery to make it more palpable. The mastectomy can be either a total mastectomy or, in fact, a radical mastectomy. The radical mastectomy may include removal of the breast, removal of even the muscle that is underneath the breast, the muscle, and some may even go as far as removing the bone if there is any bone involvement. Some surgeons are as radical as that. Indications for mastectomy include the large tumor size, central tumor beneath the areola or involving the nipple, multifocal disease, and another reoccurrence. After doing a conservative surgery, another cancer comes up. There's no need for any conservative surgery anymore. Just remove the breast once and for all. Radiotherapy is the use of ionizing radiation to burn off the cancerous tissue. In pregnancy, it's usually contraindicated. That CI means contraindicated. When I mean contraindicated, it's because of that fetus that is in the woman's uterus. Because all this ionizing radiation may affect the fetus. And that's the reason why a gynecologist is always there too. Because while the general surgeon is doing his own, the interventional radiologist is also there. The gynecologist was also take into consideration that the fetus is there too and needs to be alive. So unless it is life-saving or to prevent organ dysfunction, not organ function, organ dysfunction, we can do, we don't do a radiotherapy. And it's used only in first or early second trimester. Radiation dose usually less than 100 milligram. We minimize the radiation exposure by using the precise radiation techniques and appropriate shielding of the abdomen. You have to shield the abdomen so that this ionizing radiation will not affect the fetus. Because if it affects the fetus, if it does not kill the baby altogether, it may even cause some cancers, even in the fetus, or cause some congenital anomalies. We don't want a situation whereby while you are doing radiotherapy, you now give birth to a baby that is either born blind or born deaf or has some other congenital anomalies. One has to be very careful. Effects of radiation may include total miscarriage or stillborn. Then teratogenicity, that's the formation, congenital malformations. When a child is born without arm or without leg or without eyes, missing body parts, all this ionizing radiation can be that dangerous that babies can be born with missing body parts. Microcephaly, that's reducing brain tissue is either reduced or even absent. That's microcephaly. Fetal growth restriction, learning difficulties, induction of childhood malignancies, and of course, hematological disorders, that's blood disorders. It can cause cancer of the blood, even in the fetus. And it can also cause what we call myelosuppression. Red blood cell count is reduced, white blood cell count is reduced, platelet count is reduced. So you see that breast cancer in pregnancy is something that we can just joke about. It's really, really a concern. Chemotherapy is the use of drugs to fight cancer. They are all class D drugs. They are very, very harmful to the mother and the baby, and they can cross the placenta. It's contraindicated in the first trimester. There is a drug called anthracycline. the anthracycline-based regimens are quite safer. Other options for high risk or metastatic disease are the taxanes. Those are other drugs. All these drugs are what doctors and health workers know. It should not be given after 34 to 35 weeks. It reduces the recurrence of breast cancer by 37% and death by 27%. It's usually the treatment of first choice in stage 4 breast cancer. When there's stage 4, there's metastasis, the only best bet is to give drugs. Adverse effects of chemotherapy include intrauterine growth restriction, smaller for date baby, preterm delivery, low birth weight, transient tachypnea of the newborn, in which while a woman, after giving birth, the baby does not breathe well. There could be grunting, the baby is laboring to breathe and all that. In the supportive therapy may include other drugs like ondansetron, granulocyte colony stimulating factor, methylprednisolone, hydrocortisone, and of course psychological support that have been emphasizing, calling the clinical psychologist to counsel and reassure the woman always. Fetal surveillance is very, very important because while you are trying to treat the mother, you also have to make sure you are treating the baby too. Make sure that baby stays alive. Do a scan for anatomic evaluation. Growth scan every 4 weeks. Doppler scan if there is any concern for growth restriction. Antepartum fetal testing at 32 weeks or even sooner if growth restriction is noted. Delivery as close to term as possible. It's not by force for you to wait for 40 weeks. If the baby has already started clocking 35, 30 weeks, most doctors just do cesarean section and bring the baby out as quickly as possible. They don't want to waste time at all. But usually it's not an indication for cesarean section. But at the same time, some gynecologists, they don't care. They do the CS just to try and bring the baby out. But while doing cesarean section, we have to make sure that that woman is also stable enough for a cesarean section, because breast cancer can cause a lot of havoc in the woman already. So the gynecologist is now called in to now weigh the options. Can this woman give birth vaginally? Can this woman bear a cesarean section? Can we induce the woman, even though it's about 35, 36, can this woman go through the stress of induction of labor? Can this woman go through this stress? So a lot of factors need to come. So that's why it's not just for the general surgeon or the gynecologist to just decide on their own. No, it's a multidisciplinary approach. Usually, sometimes some doctors can even counsel the woman to just terminate the pregnancy once and for all. If they know that the baby is already compromised, there's nothing that can be done to save the baby, especially during advanced disease with poor prognosis, poor patient condition, or fetal exposure to more than that dose of radiation in the first trimester. Usually we just advise the woman, but some women, they can be stubborn to say no, they still want to give birth to that baby. They don't believe in abortion, they don't believe in miscarriage, and so on and so forth. Now, breastfeeding. Breast conserving surgery may not limit lactation if the boobs are not too affected. Lactation can still come up. It's contraindicated in women on chemotherapy because all those drugs are always secreted in breast milk. So when you are breastfeeding a child while you are taking all these chemo drugs, just know that you are giving your baby the chemo drugs too, and the baby will have all those side effects that we listed before. The time interval of 14 days from the last dose is usually the best time to start breastfeeding. Is also contraindicated if on these two chemotherapeutic drugs, tamoxifen and trastuzumab, these drugs are not given at all if you are lactating. It causes a lot of havoc on the baby. Radiation may cause fibrosis and it makes lactation unlikely. So if someone has done radiotherapy on the breast, it's very, very unlikely that it should not be done. A breastfeeding should not be given at that point. Subsequent fertility, of course, chemotherapy-induced gonadotoxicity may cause amenorrhea and subfertility. These drugs can hamper fertility. So it's possible that if you use all these drugs, you may not get pregnant again. Or that person, that patient may not get pregnant again. And there's also premature ovarian failure, especially if you do radiotherapy. If you don't do proper shielding, the ovaries may just be damaged. It's advised to wait for 2 years after diagnosis before conception. That's the best advice. Wait for 2 years before you can start taking any hormonal contraceptive method. All these hormones, they can increase the rate of proliferation of breast cancer. So no form of hormonal contraception, whether it's combination 3 or Depo-Provera, Noricerat, it is always contraindicated when a woman has breast cancer and is trying to give birth or trying to do contraception. Best thing is just to either use a condom or an IUCD that does not have estrogen implanted, and so on and so forth. Prognosis is usually very, very, very poor. Prognosis, like I said before, means outcome. Is usually very poor. Delayed diagnosis, young age at pregnancy presentation. Pregnancy doesn't appear to worsen prognosis when matched age for stage. At the same time, when a woman is pregnant, it does not always say that the prognosis is poor. Some women have actually had very good outcome, even with breast cancer, especially when detected early. When a woman has breast cancer detected early, you quickly remove that lump or the cancerous whatever. The woman can still carry on with the pregnancy, give birth to a very, very healthy child. But the commonly assessed prognostic factors may include the number of positive axillary lymph nodes, that's the lymph nodes that are under the armpit. Lymph nodes are little tissue that deal with I don't want to say filtering, but they also help, they contain a lot of white blood cells, especially lymphocytes, and those help in fighting infections. So, and they are present in the armpits. Sometimes when someone has a boil in the armpits, there are some lymph nodes that will start swelling around the boil. Those are the lymph nodes that are trying to fight the infection there. So in cancer too, those lymph nodes can be enlarged. That's and it's usually a telltale sign for a doctor. Usually when the doctor does the breast examination, they also check the armpit to be sure that the lymph nodes are also preserved. And of course, the tumor size, the lymphatic and vascular invasion, that is the lymph and blood as is flowing through the breast, whether there is any spread to other parts of the body through the blood or through the lymph. Then histologic tumor type, that's for the pathologist after a biopsy. Estrogen or progesterone receptors, like I said, the BRCA1, BRCA2, and the HER2 new overexpression. Those are the genes that I mentioned before. I don't know if there is any center in Nigeria where they do this BRCA1 or BRCA2 screening. If anybody knows about that, you can share their thoughts. In conclusion, breast cancer in pregnancy poses a dilemma for both women and their carers, especially the husband and the children, if there are any. Triple assessment with clinical examination, imaging, and biopsy provides an accurate investigation of symptomatic breast cancer. A good doctor, a very good radiologist, a very good histopathologist, all join and diagnose breast cancer as quickly as possible and intervene while the woman is even pregnant. An awareness of the current literature on limitations in diagnosing and treating it with this diagnosis. It's very, very important because albeit rare in Nigeria, it still occurs. So that's why even health workers in mother and child hospitals should also be aware that this can occur to anybody, even pregnant women. And that's why it's good to have all these sessions for antenatal providers. And that's why Lily Women's Health is here to always cater for your needs. We have a breast ultrasound machine, very good 4D ultrasound machine. We also have a portable mammogram, and we have one of the most seasoned consultant radiologists that one can ever get, who is always there to help, who is always there to counsel you and lead you through the way. And there is always an urgent need for further research on this field, especially in Nigeria. I don't know why we don't do much research in this part of the world, not only in Nigeria, even in Africa generally. All we just know how to do is to siphon money and do nothing. While in other parts, more research is still ongoing. While even they are trying to get a vaccine, in quotes, for cancer. They are researching on the vaccine so that when you just get the shot, you will never have cancer. We're researching on that, but here in Nigeria, we still believe that it's not my portion in Jesus' name. I'm going to so church. I'm going to so afar. I'm going to so mission home. They waste their time, collect their money, and in the end, the cancer would have even reached stage 4. Then they now remember that I'm supposed to go to a doctor. I'm supposed to go to this hospital, mother and child hospital, and so on and so forth. Why? We all should try and take a bold step, and that's why I'm concluding with this. Knowing it exists is not enough. You should get informed and pass it on. While you are informed, advise people to inform people, especially people that you know have this breast lesion. Advise them, no, why are you going to the church? Why are you going to this afar? Why are you going to this imam? Go to a hospital. The hospital is your best bet. Not all these mission homes, or not all these herbal people that sell all these herbal drugs on the street, at the bus stop, that will say you should take this to cure breast cancer, colon cancer, HIV, hepatitis B, hepatitis C, and everything. No. Go to a hospital and take proper treatment. If the hospital cannot handle it, they will refer you to a teaching hospital or wherever that can handle your case. And if the funds are involved, you can, I'm sorry I'm saying this, but you can fly out of the country too to get even better treatments. A lot of people that I know as a doctor have survived breast cancer. They got it early, they did the radiotherapy, they did everything, and they survived it, and they've lived for over 5 years. And I know we all can do it. And I pray that God in his infinite mercy will never allow any of us, any of our caregivers, any of our family and our friends to have breast cancer in our lives. Thank you very much. I would love to attend to questions now.
Thank you, Dr. Laguda Idris. I don't know why you didn't add Femi. Thank you very much. It's been an intensive teaching, and I'm sure all our mothers, they have taken one thing or the other, and which is going to benefit them. So now it's time for questions. Mothers in the house, please, let's begin to have your questions now. Let's Dr. Laguda Idris, let him take care of those questions. You can unmute yourself now. Hello.
Hello, good afternoon.
Good afternoon, Dr. Larewaju.
Thank you very much, Doctor, for that didactic lecture. It's after 12 already.
Yeah.
Can we actually do justice to the questions that will come?
Yes, we can still give some time.
Okay. Yes, my own is just a comment.
All right.
The doctor said that cancer of the breast is the second most common cancer in women, which is very, very true after cancer of the cervix all over the world. But for Nigeria, just because of what he has emphasized, the fact that you must check your breast and the doctors should help check, in the north, cancer of the breast is actually commoner than cancer of the cervix. And that's because of religion. We are covered up, and it's difficult for doctors to assess many of these women. They prefer women to examine them, and we don't have many of these specialists as women in the north. Therefore, this just underscores the fact that we must get ourselves examined or get the professionals to examine us so that we will be able to detect this on time, especially if there is a lump. It is important that when we go to the hospital, we get examined. Many of the women who come for antenatal, they are getting to the doctor for the first time to be examined in their lives. And because of the privacy of that place, most of the time when you ask them, do I do this one? They say, no, I don't have problem. In Jesus' name, it's okay. You see, and I just ask them, do you check yourself? I hope you don't have this, you don't have family history of this, because it is sometimes a little bit embarrassing for us to be examined. If there's nothing to be embarrassed about, make sure that the doctor sees you and examines you, because that may be the only time the doctor will have access to your breast when you are pregnant. I pray we won't wait until it is too late. Secondly, is the issue of mammogram and breast scan. I don't know why, many of us, we don't do medical tests. And the way this cancer is going now, as it is said, even in Nigeria, they say a person is dying every 26 minutes for one cancer or the other, every day. And you can see that is very, very high. If we take cancer of the breast and cancer of the cervix, majority of the people, these women, will live longer. Therefore, please, let's make sure that when we get to the hospital, the doctors examine you, which is important. The third thing I want to say is on the lump. Some people will come with lumps. They even dictate it. And they will tell you, the doctor tells me it's a benign lump. I should not worry, especially when they have gone abroad and somebody has done a scan for them and they just assure them. And when they come here and you tell them, go and remove that lump, they say, no, my doctor say it's benign. You cannot say a lump is benign until you take it out. Thank God for what the doctor has said now. Ultrasound cannot tell you it's 100% benign. Even mammogram cannot say it is 100% benign. Get any lump out before it's too late. Thank you very much.
Thank you, Dr. Larewaju. Please,
Thank you very much, sir.
Okay. Can we unmute ourselves and ask our questions?
Thank you very much, Doctor.
Okay.
Wonderful. And my question is, so how do we carry out a proper breast self-examination at home?
Dr. Idris.
Thank you very much. Okay. Yes, thank you very much for that. I wish I was with my laptop. I would have played a video on this breast self-examination so that I can share it, and I don't know how I can even share it so that people can have it on their own devices, but I can just do a little bit of running through. After having your bath, standing, usually some doctors say immediately after your menstrual cycle, because that's the point where the lobules have really reduced and you are sure that the lobules are not as prominent as it was before. But some other doctors say it doesn't matter, you can do it at any time. So after having your bath, stand in front of the mirror and look at your breast. Stand in front of it. That's the first thing. Just look at it. Is it symmetrical? Is there any contour, any irregularity on the breast? Look, while you are looking, stand, you turn to the right and you turn to the left while you are looking. You hope the breasts are bouncing very well. It's not as if it's fixed. It's not as if one is bigger than the other. Look to your right, look to your left. Then the next thing to do is to raise your hands up. while you are raising your hand, if you are feeling that one breast is pulling down while you are raising your hand up, as you are raising your hand up, the breast should not pull down on you. It should not as if the breast is dragging on you. If you are feeling that the breast is dragging down on you, then there's a problem. That means there is a lesion there that is being fixed to the muscle. So one has to be very, very careful. And while you are raising your hand up to look round, check turn to the left, turn to the right. While you are in front of the mirror, check again if there is any contour, if there is any dimpling, any nipple inversion, and all those signs that I mentioned. Then after that, after you have done that, you lie down, put a pillow under your shoulder, the breast that you want to check. You do it for the two breasts. Then you start from the nipple. You put your hand on the nipple. You now go either, usually they say clockwise. You rub the breast in a clockwise fashion. You start from the nipple and you go outwards and you check all around. Don't try as much as possible not to miss any part of your breast. Try. With more practice, and there are a lot of videos on YouTube too, with more practice, you will be able to do the breast self-examination very well. And one other thing, please, a lot of women, while they are doing the breast self-examination, they always miss the armpit. They don't know that a part of the breast is inside the armpit. They don't know. So while you are doing, also check the armpit to be sure if there are any lumps, if there is any lymph node enlargement or whatever. Check the armpit too while you are doing that. And while you are doing, while you are palpating on one breast, put the pillow on the under the other shoulder and palpate too. And that's just about it for a breast self-examination. There are many videos on YouTube where you can even assess this better.
Thank you, Dr. Idris. I hope that mother is satisfied with the question. Hello?
Yes, thank you very much.
Okay. Please, let's keep our questions coming. This is an opportunity for you to clarify a lot of things you have seen or you have heard. Hello? Mothers in the house?
So there's no question, there's no contribution. So
okay. I hope we all enjoyed the teaching. And if you have any question, if you cannot ask now, please, when you come to the hospital for your clinic, please ask your doctors or ask from the nurses. We will be available to help you. Thank you very much. Dr. Idris.
Thank you so much for having us.
You're welcome. I can see somebody. Do you want to ask a question? Okay. Thank you very much. Dr. Bankole, thank you. Thank you, everybody. We'll see you again in another fortnight.
Thank you, Ma.
You're welcome. Thank you.